So today we are going to have the discussion on testicular cancers. 4 candidates has volunteered to do the scenarios. We'll do 10-minute scenarios for each of them. This session is recorded and this will be uploaded to the YouTube for the benefit of other trainees. All the candidates has agreed to record this and disseminate in the social media for academic purpose. So we'll go with the candidate number 1. So I'll start the recording. So you are reviewing a GP letter, 2-week wait letter, for a 26-year-old gentleman who was referred as a 2-week wait for testicular mass on the left side. There are no other details given in the 2-week wait letter. How are you going to arrange his outpatient appointment?
I would organise to see this gentleman urgently in my 2-week wait clinic with a cancer nurse specialist. Upon review of the patient, I would ascertain if he understands why he's been referred by his GP, ascertain which side he has noticed a problem within his testicle, how long he's noticed the lump for, if it's painless, if it's increased in size, if he's had any other systemic symptoms such as weight loss or fever, whether he's had any previous scrotal surgery or undescended testes as a child, and any family history of testicular cancer. Also ascertain if he's had any previous STIs, any lower urinary tract symptoms, and then clarify his comorbidity status, including drug history, allergy status, anticoagulation status, and social history. From there, I would proceed to examine him with a nurse chaperone, examining his general health and weight, making sure he's not cachectic, making sure I could feel no abdominal masses, then proceed to examine him, his penis, and his testicles, specifically examining the normal side first, which I believe you said the left side was the one with the lump. So the right side, ascertaining the size, the texture, and then on the left-hand side, examining for a mass, whether this is intratesticular or scrotal, if it's fixed or mobile. I would then proceed to organise some further investigation for him, depending upon my findings.
Okay. So what are the risk factors of developing a testicular cancer?
So age can be related to a different type of testicular cancer. So if they're above 60, lymphoma, and if they're under 10 years old, yolk sac tumours. Family history, if the father had testicular cancer, there's a 6 times increased risk. If there's a brother that's had testicular cancer, there's an 8 times increased risk. And undescended testes, 10% of patients have a 4 to 6 times increased risk of testicular cancer. If they previously had contralateral testicular cancer, there's a 10% increased risk.
Okay. So can testicular cancers present bilaterally?
Yes, they can, but that's less than 1%.
Okay. So in this patient, when you examine him, he's otherwise fit and well, no medical or surgical comorbidities, no history of previous cryptorchidism or any surgeries in the inguinal or groin or scrotal region. On examination, there is a hard lump palpable in the upper pole of the left testis, otherwise mobile. Spermatic cord appears fine, non-tender, no family history. He's 26 years old. How are you going to proceed from here?
I would explain to the patient that I'm very concerned he has a testicular cancer on the left-hand side. I would explain that he would require a few investigations, namely some tumour markers, which would be beta-HCG, alpha-fetoprotein, and LDH. I would also perform FBCs and Usinese, specifically Usinese because he will need a staging CT thorax, abdomen, and pelvis. I would also discuss with this gentleman, because he's 26, I would ascertain his family status, whether he has had any children, or if he's interested in childbearing in the future, and explain that he is likely to need some sperm banking, for which case we would also consent him for HIV, hepatitis C, and syphilis, and then also discuss with him a prosthesis insertion. So my initial investigations would be those blood tests, an urgent ultrasound testes, which I would take him down to the department and try and perform on the same day, and also an urgent CT tap.
Okay. So your radiology department is very proactive. They agreed to do the ultrasound scan the same day. Now you got the ultrasound scan report which says that there is a 2.5 centimeter hypoechoic mass in the upper pole of left testis and bilateral microlithiasis. The right testis is completely normal.
Okay. I would explain to the gentleman that he would need to be listed urgently for a radical left inguinal orchidectomy. I would review all of his results, which would be his blood test, his staging CT, in my MDT. But in the meantime, I could organise for him to have sperm banking prior to his radical orchidectomy, and then also organise a prosthesis should he wish to proceed.
Okay, so his tumor markers are negative. His CT scan is not showing any retroperitoneal abnormalities. No other. This chest is clear as well. What are you going to do with the finding of microlithiasis in ultrasound scan?
So there is a risk of contralateral intratubular germ cell neoplasia. I can't remember the exact risk, but he's young. The tumour is small on the left-hand side. So there's no history of undescended testes. Can I just confirm that?
There's no history.
Yeah. So I don't think he necessarily warrants a contralateral biopsy. I would explain that would have to be monitored with ultrasound surveillance, but the key thing would be to proceed with the left inguinal orchidectomy.
Okay. So this patient is coming on your theatre list. So you have seen him in the surgical arrivals, explained once more. He confirmed that he has read the information leaflet. He's willing to have the testicular prosthesis insertion as well. So in the theatre, he's prepped and draped, WHO checklist done. How are you going to proceed?
So I would make an incision over the superficial inguinal ring, make sure that, he is marked as well, and covered with broad spectrum antibiotics, make an incision over the inguinal ring, dissect down to find the spermatic cord, identify the cord, clamp the cord, open up the external oblique so that I can identify the cord at the highest point. Remove the testicle. As I mentioned, I placed 3 Robinson's clamps. 3 clamps. I would dissect the tumour, send this off to histopathology. I would then put some ovicral transfixation sutures as well as a fixation suture at the end of a PDS at the end of the cord itself as a marker. I would then close the inguinal canal, and then in terms of the prosthesis, ensure that this matches the other side, and then bathe this within betadine, try to use minimal touching of the prosthesis, put a reverse suture of proline through the top loop, places backwards through the top loop of the prosthesis, and then secure this to the fundus of the scrotum, and then feed this down into the scrotum, making sure that the prosthesis sits in a nice position, and then I would close the skin, close the fascial layers with Vicryl, and then close the skin with monocryl as well. Sorry, very nervous.
So you are sitting in the MDT afterwards. The pathologist says that it is a 2.8 centimeter seminoma in the upper pole of the right testis, upper pole of the left testis, the specimen. What other parameters do you want to know from the pathologist?
Whether or not there's Ricci testes involvement, whether or not seminoma is the only component, and to ensure that it's less than 4 centimeters, because if it's greater than 4 centimeters, or if there's retestis involvement, this puts the patient at a slightly higher risk.
Higher risk of
progression.
Okay. So this is 2.8 centimeter. There is no retestis invasion. Your radiologist reviews a CT scan and the retroperitoneum is clear. What is the stage of this tumor?
So he's a stage 1. He's a stage 1 seminoma. Okay. Oh, do you mean TNM staging?
No, clinical staging.
Oh, clinical staging. He's a PT. Did you say, there is lymphovascular invasion or no?
No. So this is a clinical stage 1 seminoma.
Yeah.
What do you think will be the treatment option for this gentleman? What are the options for this gentleman?
So he could either have surveillance, where we monitor his tumor markers. He could receive 1 dose of carboplatin, or receive radiotherapy 20 to 24 grays.
Okay. So there is no risk factors for this gentleman. His seminoma is less than 3 centimeter. There is no retestis invasion. I'll stop it there. I'll just complete the question. What do you think is the risk of relapse for this gentleman?
I think he's in the good prognosis group. So overall, I believe that in terms of his cancer-specific survival, it would be 86%. So his risk of progression is low.
Okay.
But yeah, so I guess the discussion is whether or not he would benefit from carboplatin. I probably would suggest it if he had any of the other risk factors.
Okay, excellent. So we'll stop there. Regarding, so how was it?
Oh, I got really nervous. I don't know why. Sorry. So when I was describing my surgery, that was a bit that I got most nervous on, I think. Maybe because I haven't described it out loud as much as the other things. And then I think with testicular cancer, there's always that when you get asked what is the stage, I never know whether or not to give the TNM staging or whether or not to give the stage in terms of the prognosis groups. So I'm sorry if I answered that incorrectly.
No. You did well, I would say, from my feedback. It's always a confusion regarding these things, isn't it? So there's a TNM staging, there's a clinical staging, and there is the higher risk staging, the IgCCCG risk classification. I think you did well in the initial part. There's nothing missing there. You rightly said that you will discuss about the completion of family and the cryopreservation. Well done. Regarding the risk factors, not much of a trouble, but regarding the family history, the relative risk is less if the father is affected. It is 2 to 4, and if the brother is affected, it is 8 to 12. Not much of a. You studied rightly, but I think it went the other way. If you hear back the recording, then you will recognize that.
Okay.
But it's not a big thing. And you rightly said about the cryptorchidism, relative risk of 4 to 6. Well done. There's no concerns regarding the examination, the way you took it forward. You involved the cancer nurse specialist, you involved the MDT within the allowed time limit. And 4 centimeter, that was the one that I was confused regarding the risk factors. So in the EAU guidelines, it says 3 centimeter, isn't it?
Okay.
The risk factors. I think in one of the books it is written as 4, but recent guidelines, the cutoff limit is 3.
Right.
And by the end, for the clinical stage 1, I think you mentioned about the good prognosis, but the prognostic classification, the good and intermediate, is we talk about the prognosis only for the metastatic germ cell tumors, including stage 2C.
Yes.
So in this scenario, we don't have to discuss about the IgCCG risk classification because this is a clinical stage 1 seminoma confined to the testis with no retroperitoneal. And the keyword that I was looking for, that the risk of progression, yes. I mean, if all these things are negative, if there are no risk factors, what is the risk of? It's mainly it's a risk of relapse in the retroperitoneum that we are looking for.
Yeah. Okay. Okay.
So, just use the right keyword. Otherwise, it was excellent. I'm just fine tuning some of the words. Nothing. There's no concerns. Well done.
Okay. And then, so in this chap, because he didn't have a tumor size greater than 3 centimeters or reach testes involvement, would you recommend carboplatin or EBRT, or is it only if they have those risk factors?
So it's again. The nice way to get out of this is involving the MDT and saying that all these 3 options are open to him, and it's only most of the time in UK 1 cycle of carboplatin is the preferred one, because because this patient has no risk factors, so the risk of relapse in the retroperitoneum is around 6%. We can bring it down to 3% by giving a 1 cycle of carboplatin.
Okay.
So it's more like a shared decision. The most important thing is if the patient agrees to it, and 2, if you think that the patient will comply with the follow-up.
Yeah. Okay.
So these 2 determinants, there is not much of difference, I would say, even though when we think about the absolute risk reduction, it might appear that it is 50%, but when you look at the relative, you can see that it's from 6 to 3. So it will be a discussion between the oncology team and the patient, and this is more like a shared decision.
Yeah. And how was my description of the actual inguinal nodectomy?
Yeah, I mean that's the right way to say it, because what they look for is whether you are a safe surgeon, but you have to show that in 40 seconds, maybe between 40 to 60 seconds, because we don't have to waste much of time in that one, isn't it? So you did it nice in the way that you stick to the time limit, given that you finished it within, I think you completed that answer within 40 seconds, which was really good.
Okay. And then, sorry, one last question. So when you were asking me the staging, should I have been giving you the TNM staging?
No, because what I was looking for was the treatment. So I was thinking about clinical staging, but that's not a big difference there, because if the examiner wants that, he or she will always come back to you and confirm that, because you are doing really well. So even if you start to say about TNM staging, I think as an examiner what I do is I will politely interrupt and say, no, I was looking for a clinical staging.
Okay. Thank you, Mr. Pushkaran.
Most welcome. So shall we go for the next candidate?
Yeah, I'm ready.
Excellent. So can you tell me about the end staging, nodal staging in TNM?
I didn't hear the question.
Sorry, can you describe the nodal staging in TNM classification, AJCC TNM classification?
Yeah, right. So in N1, if lymph node size less than 2 centimeters, in 2 if between 2 to 5 centimeters, in 3 more than 5 centimeters.
Okay, so you are sitting in your MDT, and there is a patient who already had a right orchidectomy, and it is showing non-seminoma. The CT scan shows 3 centimeter lymph nodes, paraiotic lymph nodes. Chest is clear. He is 28-year-old. No other risk factors, otherwise fit and well. Can you tell me what would be the TNM staging for this gentleman?
Okay, right. And the CT scan is not showing any lung metastasis?
No.
Okay, right. So he will be at stage 2B, according to the information given.
Okay. What risk factor that you want to know from the pathologist?
Right. So the main risk factor, I'd like to know whether there is lymphovascular infiltration. Previously, embryonal element and rate of proliferation were considered. However, according to recent GRBAN guidelines, only lymphovascular invasion is the one considered as a risk factor in non-seminoma.
Okay. And what's the difference if there is lymphovascular invasion or not in the risk of relapse?
So the risk of relapse in non-seminoma, in the absence of risk factor will be around 15%, and the presence of risk factor would be up to 50%.
Okay, so this gentleman has got a non-seminoma. It is confined to the testis.
I'm sorry, there was a cut in the line.
I'm sorry.
Can you say it again?
Oh yeah. So this gentleman, the final staging of this gentleman is a non-seminoma confined to the testis with a 3 centimeter retroperitoneal lymph node. There is no lymphovascular invasion. How are you going to? What do you think are the treatment options for this gentleman?
Okay, right. So his treatment options would be he is as I said, he's stage stage 2. Can you tell me the levels of the tumor markers, please?
It's normal.
Oh, normal.
All normal.
Okay, right. Well, he would be of good prognosis according to CCCG
Sorry.
prognostic criteria.
I'll confirm it once more. Sorry. So this patient is stage 2B.
Yeah.
What do you think are the treatment options for this gentleman?
Okay, right. So his treatment options are either chemotherapy, 3 cycles BEP, or retroperitoneal lymph node dissection.
Okay. What all factors you look for before you prescribe bleomycin?
So basically, I would like to know the patient age and also whether he has any history of lung disease and whether he is smoker, and also we'll need to assess his kidney functions as well.
Okay.
Usually we would like to know whether he has any hearing defects, and sometimes we consider hearing tests before we start the chemotherapy.
Okay. So how many cycles of BEP would you prefer for a stage 2B non-seminomatous germ cell tumor?
Right, I would consider him for 3 cycles BEP.
Okay. And if a patient has got contraindications, you nicely mentioned all the contraindications. So if a patient has got any contraindications for bleomycin, what do you think would be the treatment option?
So his treatment options would be either 4 cycles EP, etoposide cisplatinum, or PEI, which is cisplatinum etoposide ifosfamide.
Okay. So you said that the options are between chemotherapy and RPLND.
Yes.
Are there any specific factors in the primary tumor that might influence your decision between chemotherapy and RPLND?
Well, in general, if the patient is not willing or not agreeing to have chemotherapy, we go for the retroperitoneal lymph node dissection option. Okay. In regards to the primary tumor, if it is teratoma is less responsive to chemotherapy, and therefore retroperitoneal lymph node dissection would be the best option.
Okay, excellent. So, if this patient had the 3 cycles of BEP and the repeat CT scan shows residual mass, what would be the further treatment or further investigation that you would prefer?
Okay, right. So according to the size of the residual mass or the recurrence mass, if it is less than 1 centimeter, then he can be safely followed up with surveillance. If it is more than 1 centimeter, and then and I will undergo repeating his tumor markers, and if they are positive, then we'll consider him on salvage chemotherapy. And then for 6 weeks later, when his tumor markers are normalized, then we can do retroperitoneal lymph node dissection.
Okay. So what percentage of residual masses has got active cancer in them?
Yeah, so usually the specimen will show 50% necrosis, 35% mature teratoma, and 10 to 15% active tumor.
Okay. Is there a role for FDG PET in the situation of recurrence of residual mass in a non-seminoma?
Well, the FDG PET scan has role in seminoma, but I'm not aware that it has any role in non-seminoma.
Excellent. If the MDT decides for a RPLND for a persistence of mass, considering that it could be a teratoma, how would you counsel the patient?
Okay, fine. So we'll explain to the patient. Well, basically, this patient will need to be discussed in SMDT and referred to a tertiary center where there are experiences of doing retroperitoneal lymph node dissection, either open or laparoscopically. So I will give the patient Bow's information leaflet about the procedure, explain that we intend to remove the lymph nodes extending from the renal artery down to the iliac vessels. It comes with potential complications in the form of mortality 1 to 3%, morbidity 5 to 25%, 15% risk of anejaculation, 15% risk of lymphocele, 5% risk of chylous ascites, bleeding, infection, injury to the vascular injury, and planned nephrectomy, 5%. And also there is a risk of bowel injury, and 1% risk of spinal ischemia.
Excellent. So we are almost time there. We'll stop there. How was it?
Yeah, it was okay. I don't know why probably in the beginning wasn't the best part, but later on, I think I went okay with the flow.
Yeah, sorry, I put you in a difficult situations to start with, because I was planning to continue from the previous situation. You did really well, I would say. All your percentages and the way you took the Viva forward for almost 9 minutes 28 seconds was, really good. You rightly said about the side effects of bleomycin. I got all these points here. You mentioned all those points. Well done. You correctly diagnosed the stage, and you have got really good knowledge on how to manage. You didn't waver at any point of time, thinking that no, this is not a scenario that I have to practice. But yes, well done. Any questions you have?
Well, thank you very much. That was great.
Excellent. And most of the time, this will not be the open scenario. You know that, isn't it? But having this much of in-depth knowledge will give you more confidence, so that you will always try to progress in that one. Because as you know, by the end of scenario, it will be these things that will be discussed. Well done. And you said rightly that the FDG PET, according to the guidelines, there's no role in non-seminoma. It is only used in seminoma with residual mass more than 3 centimeter, isn't it?
Yes. Just one thing to mention. I would recommend everybody taking this FRCS urology exam to listen to Mr. D videos, and of course you were so much involved in those videos. They are so beneficial, and I would recommend everyone to listen to all of the videos.
Oh, that's good.
They are really good.
Thank you. Thanks for the nice feedback. Thank you. Excellent.
Thank you.
So shall we go for the third candidate? From this point onward, is more theoretical questions I'm going to ask, because now we had 2 excellent scenarios and excellent performance as well. So you know how good you can be when you know the answers. So who is going to? Shall I start?
I'm going to do the third scenario.
Excellent. So we'll go through some of the difficult scenarios, difficult questions that you might face in a testicular cancer scenario.
I'll try to answer them.
Yeah, and I would suggest not to feel bad, because it's a bit of paradox, isn't it? Because as we perform well, we will end up in the by the end of the scenario, as you can imagine, in the key paper or the key that is given to the examiners, most of the time by the end of the scenario it will be really difficult questions which will be more like difficult scenarios, and you might end up thinking that you did bad, because most of the time we will remember only the last 1 or 2 minutes of the viva session. This happened to me in the bladder cancer, where at the end I couldn't answer most of the questions because the questions were like, what is the recurrence of stricture in a ileal conduit at the anastomotic site, at the ureteroileal anastomotic site, and I was thinking that I'm not answering anything, but later I realized that because when you perform well, that are the questions that you will get by the end of the scenario, and you will end up in a situation where you feel that you haven't answered anything, but and the paradox, you have done well for 8 minutes and you can expect some difficult questions at the end. So a couple of things. One, okay, we'll start now. What is the serum half-life of AFP?
It is 5 to 7 days.
And beta HCG?
24 to 36 hours.
Excellent. And what is the importance of serum tumor markers?
Serum tumor markers are helpful in diagnostic, staging, and prognostic.
Okay. And so if you are doing if the serum tumor markers are normal before orchidectomy, how long after orchidectomy will you repeat the serum tumor? Would you repeat the serum tumor markers if it is normal pre-op?
Yes, I will do.
And how long after you will repeat that?
I will do it at after 7 days.
Okay. So what is the importance of seminoma, AFP in relation to seminoma in the histopathology?
Well, alpha fetoprotein in seminoma is not raised. It is a tumor marker which is usually raised in yolk sac tumors. So in seminoma, there will be normal alpha fetoprotein.
Okay. So if the histology is seminoma and if the AFP is raised, what will be your diagnosis clinically?
Well, I will clinically feel that there must be some non-seminomatous element in the specimen. So I will ask the pathologist to review the histology.
Okay, excellent. And for the beta HCG, what are the other scenarios in which beta HCG is elevated apart from testicular tumor markers?
Beta HCG can be elevated in lung, liver, pancreas, and benign liver disease, as well as in marijuana smokers, and also in patients who are hypogonadal, wherein there is a raised LH. In those cases, the patients who are primary testicular failure, where there is a rise of LH, the beta HCG can be spuriously increased.
Okay. What are the scenarios in which you would consider the option of testicular or testis sparing surgery?
Testis sparing surgery is indicated in patients with testicular tumor volume less than 30% in a single testis, and in a suspicion of a benign tumor in the testis. So in these cases, testis preservation surgery may be indicated.
Okay. Can you tell me briefly the operation scenario while you are doing a testis sparing surgery? What all precautions will you take while you contemplate testis sparing surgery?
In testis sparing surgery, I will like to do intraoperative ultrasound to see the testicular tumor. Before the operation, I will do at the time of the operation, intraoperative testicular ultrasound, and I will also ask for a frozen section before I complete the procedure.
Okay. Are you aware of the procedure called as Shivasu maneuver?
Yes, I mean, in that procedure, you split the testis in the longitudinally along the axis, and then split it, and then take the tumor out from where it is, and leave the rest of the testis. And
Excellent. What are the side effects of testis sparing surgery?
the side effects are again a bleeding, infection, pain. There can be some recurrence which can happen. Yeah, that's it.
Okay. What is OngoTC?
OncoTC is a procedure to retrieve sperms from a patient who has testicular cancer. This is to be done, getting the testis opened up from the tunica vaginalis, tunica albuginea, and then getting the good spermato, the good sperms to be taken under a microscope.
Okay. So, what percentage of patients with testicular cancers are azoospermic?
Yeah, it's around 25% of patients who are azoospermic can have testicular cancers.
Okay, excellent. And if you are planning for a sperm cryopreservation, what time would you advise a patient to have that done?
I will ask the patients to do it before the operation, and it can also be done within a week after chemotherapy.
Okay. How long it will take the semen parameters to recover after the chemotherapy?
Usually it takes around 3 years to recover if he has a full cycle of BEP.
Okay, excellent. So, I think we'll stop there. So, how was it?
I think I got most of the answers right, but somewhere I was a bit not able to clearly say regarding that Shivashu's procedure, and I don't know how did I do regarding OncoTC.
Yeah, I would think to explain it a little more regarding the OncoTC. So coming back, you did well on most of the aspects, because these are the scenarios where the questions are a bit vague and there is no clear-cut definitions in the guidelines. All of these things, even the OncoTC is like an upcoming thing, and it's only done in some tertiary centers, especially when we see patients with azoospermia. That's when we send these patients to the tertiary centers where they offer the option of OncoTC. And you said rightly about the percentage that was spot on: 24% persons with azoospermia and 50% persons with oligospermia. That's the whole point, that we counsel the patient to have the sperm cryopreservation, ideally before orchidectomy, but if it is not possible due to logistics and the local availability, at least before chemotherapy. But again, if it is already oligospermic patient, if it is done after removal of the testis, there is a risk that the sperm count will be less. So that's why we always try to do it before you go for the orchidectomy. Regarding the other effects, other causes of beta-HCG, you have nicely mentioned everything. I would try to use the keyword cross-reactivity between LH and the beta-HCG.
Yeah.
And no other concerns. One thing, because I think this question can be asked regarding the indications for testis sparing surgery. You rightly said solitary testis, and if there are synchronous bilateral tumors, metachronous contralateral tumor, And yes, in very rarely, if there is suspicion of benign tumor, and especially if it is in a solitary testis, if there are bilateral, if the both testes are otherwise normal, and if there is a lesion in one of the testes, mostly almost all the time we have this shared discussion with the patient and inform the patient that it is better to undergo radical orchidectomy because other testis is normal. So it's more like a shared decision if we suspect a benign tumor. So I would think to bring the keywords synchronous and metachronous, especially when you discuss the testis sparing surgeries. This might come especially when you, even in a normal scenario, while you are discussing the orchidectomy, sometimes the question can pop up like, okay, what difference, what would be the difference in your approach if it is a testis sparing surgery? So you said rightly all the things, and you can start with that indications, and then you can say that I'll always make sure that there is a frozen section available, because that is a decision making, isn't it? And the risk factors are the intraoperative risk factors, the immediate postoperative risk factors of bleeding are more with testis sparing surgery, and even the risk of testicular artery injury, the chance of testicular atrophy is more, and also the chance of local recurrence in the same testis is more when you offer the option of testis sparing surgery. Coming to OncoTC, yes, if the patient is if the sperm cryopreservation shows azoospermia, patient has they couldn't collect a semen sample to cryopreserve, then we have to refer as an immediate over the phone referral to one of the tertiary centers where they have to do the TC at the same time. And one of the other question was how long after the sperm counts recover after chemotherapy. Don't think that's an important question, but still the answer is 1 year according to the EAU guidelines.
Okay, but actually, I was knowing the fact that if a patient has a chemotherapy, it usually takes around 3 years for them to recover.
Okay.
To have the sperms.
Okay, so in the EAU guidelines, it is based on a paper in 2019, Weibring. So, I mean, if there are any other papers, yes, that would be the right answer. But I just stick on to the guidelines. So maybe the reason that I'm sticking on to the guidelines is I think the answer key given to the examiners are based on guidelines.
Okay, so is it 1 year? I knew it as 3 years actually.
Yeah, you can review the so there is a section of fertility and testicular cancer in EA guidelines. So if you refer to that part, I mean, I don't know whether that question will be asked in the exam, but that was asked to me in one of the mock exams. That's why I put that in my presentations.
Okay.
Excellent. So shall we go for the final scenario then?
Yeah.
Excellent.
Yes, please.
Again, this will be in-depth discussion of the scenarios we have already visited once. Okay.
Okay.
Okay. What is the pathological classification of testicular tumors?
So testicular tumors, oncologically, they are non-seminomatous germ cell tumors, and sex cord tumors, and others which are, for example, lymphoma or epidermoid cyst or metastatic tumors.
Okay. What is GCNIS?
So that's germ cell intra.
Okay. So when would you suspect that there could be GCNIS in the contralateral testis if a patient is presenting with testicular tumor?
Sorry, come again?
If a patient is presenting with testicular tumor, what are the situations in which you think that there could be GCNIS in the opposite testis?
So the risk factors for GCNIS in the opposite testes is if the testis is smaller in size and the age of the patient is more than 40 years of age.
Okay. So what would you do in that situation?
So in these circumstances, the patient should be counseled for a biopsy of the contralateral testes whilst the patient is having oculectomy for the tumor, for the testes that has tumor.
Okay. And how do you do the biopsy of the contralateral testis?
So prior to this biopsy, the patient should have an ultrasound scan, and if there's any particular area of interest, abnormal area of interest in the contralateral testes, then it should be biopsied by incising the testes in the longitudinal plane and opening the testes up, and the abnormal area should be excised and sent for further section. If there is no particular area of interest, then the patient can have random biopsies from the testes.
Okay. So what approach would you select? Is it a scrotal or an inguinal approach for the biopsy of the contralateral testis?
I think I will offer the scrotal approach. However, if this is shown as a testicular tumor, then this can be converted into an inguinal approach if orchidectomy is required.
Okay. So for discussion purpose, let's think that a patient with a testicular tumor on the right side with the opposite side history of cryptorchidism and the ultrasound scan showing less than 10 mils of testis, and the patient is less than 40 years of age. You are planning for a scrotal biopsy. How many samples will you take?
So in patients that on ultrasound scan pre-operative imaging do not show any particular area of interest, then I will take one biopsy from each quadrant of the testes, so at least 4 biopsies.
Okay, and will it be an open biopsy or a true cut biopsy?
I'll do an open biopsy.
Excellent. And is there any particular solution that you will send that biopsy in?
Yes, testicular tumors should be sent in Bowen's solution.
Okay. So, and when you are discussing in the MTT, if the pathology says that there is GCNIS in the testicular biopsy, what are you going to do with that information?
So I will explain to the patient that the chances of him developing a testicular tumor is in the next coming few years is high, and if the patient has not had his sperm banking done, then the patient should be counseled for this. The patient should be offered the chance of either surveillance or an upfront orchidectomy. If the patient chooses to have an surveillance, then the patient should be taught self-examination and sequential surveillance ultrasound scans every 3 to 6 months for the next few years until he has completed his family. Patient should also be counseled that if both of his testes are removed, that he will need to have some testosterone replacement lifelong as well.
Okay. So what is the risk of developing a testicular cancer at 5 years if the specimen shows GCNIS?
I think it's 50% at 5 years.
Excellent. Well done. So